All right, future nurses, welcome. Today, we're going to cut right through all the noise about eating disorders. We're talking practical, need-to-know info that you're actually going to use. Yeah, this will help on your exams, but way more importantly, it's about building that confidence and competence for when you're on the floor caring for real patients.
So before we get into any of the clinical stuff, let's just get this straight. This right here, it's the most important thing to understand. Eating disorders are serious, they're complex, and they are not a choice. They're not a diet gone wrong or just some phase. Getting this right from the very beginning, it changes absolutely everything about the care you're going to provide. And, to make this as real as it gets, we're going to walk through this whole thing with a patient. We'll use her case study to connect every single concept directly to clinical practice. That way, you can see exactly how to apply this knowledge, step by step. Okay, let's dive right in. Look, to be a great nurse, you need really sharp assessment skills, and that all starts with knowing exactly what you're looking for. So first things first, let's clearly define the 3 core eating disorders you're most likely to see. Now, you're going to want to pay close attention here, because this slide is absolutely crucial for building that clinical gut instinct. See the key differences? For anorexia, the hallmark is severe restriction that leads to a significantly low body weight. With bulimia, you're looking for that cycle of binging followed by some kind of compensatory behavior, like purging, to prevent weight gain. Then there's binge eating disorder, where you have the binging, and this is key, without those compensatory behaviors. Nailing these distinctions is absolutely step 1. And this is just a brilliant illustration of the fact that these are systemic illnesses. This isn't just something in their head, it's in their heart, their bones, their kidneys, everywhere. We're talking a slowed heart rate, brittle bones. The physical consequences are profound and they affect the entire body. And that is exactly why your head-to-toe assessment skills are so important. So let's get practical. How does all this translate to your role at the bedside? Well, this next part is all about connecting what's in the textbook to the actual person sitting in front of you during your physical assessment. So what are they? What are those key physical signs that you can never, ever miss? The red flags that should immediately make you stop and think. Well, we've got 2 really powerful mnemonics for you. And trust me, these are fantastic memory tools to help you lock this stuff in so you can pull it out when you're under pressure. First up, for anorexia nervosa, your memory key is a simple phrase: low weight. Each and every letter is going to cue you in on a critical assessment finding. Let's just walk through a couple of these. L stands for lanugo. That's that fine, downy hair the body grows. It's kind of this primitive way to try and stay warm. H is for hypotension and bradycardia. Remember, the heart is a muscle, and during starvation, it weakens and slows way down to conserve every last bit of energy. And E points to electrolyte imbalances, which, as you know, can trigger deadly cardiac arrhythmias. Every single letter here represents a serious physical toll on the body. Okay, now let's talk bulimia nervosa. For this one, your big aha assessment findings are often linked to the act of purging. So our mnemonic is a word that actually describes the behavior itself: purges. For this one, your assessment focus is really going to be on the head and neck area. P is for parotid gland swelling. That's what gives that characteristic chipmunk cheek look. G stands for gum disease and just severe dental erosion from all that repeated exposure to stomach acid. And R is for Russell sign. Those are the calluses you'll see on the knuckles. These are classic telltale signs you have to be able to spot. And what's really powerful here is you can see these signs with your own eyes. On the left, there's that fine, downy lanigo. In the middle, you can see that just devastating dental erosion. And on the right, that really distinct parotid swelling. These aren't just words in a textbook, right? They're real physical signs of the illness that you will see in your patients. Okay, so you've done your assessment, you've spotted the signs. Now comes the most crucial part: recognizing when your patient is on the verge of a crisis and knowing exactly what to do to intervene safely. One of the absolute biggest risks you have to anticipate is something called refeeding syndrome. This is a potentially fatal complication that can happen when we, the healthcare team, start to refeed a severely starved patient. Let me be really clear here. Your understanding and your vigilance about this syndrome can literally save your patient's life. So, how does this happen? Well, the best way to really get it is with an analogy. I want you to imagine the body in a state of starvation is like a factory that's been completely shut down to save power. The lights are off, the machinery is just sitting there idle. Everything is in this low energy preservation mode. Now, when we start refeeding, it's like we walk over and throw the main breaker switch back on. Bam! There's this massive surge of insulin to push glucose into the cells for energy. But to make that energy, the cells need a critical component. Think of it like a spark plug. And that spark plug is phosphorus. The insulin forces all the available phosphorus from the blood into the cells all at once. This just tanks the serum phosphorus levels, leading to a state called hypophosphatemia, and that can cause the heart and lungs to fail.
And this is exactly why getting the patient to the right level of care is so incredibly important. A patient who's at high risk for refeeding syndrome, they need to be on an inpatient medical unit, not just a psychiatric one. Just look at these objective criteria: a heart rate under 50, a body weight below 75% of what's ideal, or major electrolyte problems. These are red alerts for severe medical instability, and they demand hospitalization, period.
Okay, it's time to bring it all home. Let's go back to our 19-year-old patient and apply this whole framework to see what her clinical picture is really telling us.
Remember her vitals: a heart rate of 55, blood pressure of 90/60. Now that you know everything we've just talked about, are those numbers setting off some alarm bells for you? They absolutely should be. That's not just a number on a chart, it's telling a story.
So let's connect the dots here like a detective. That bradycardia and hypotension, they're classic signs pointing to the incredible physiological strain of anorexia nervosa. Because of that, her number one immediate risk is going to be refeeding syndrome as soon as we start nutrition. And given that her heart rate is just hovering right above that critical threshold of 50, the only safe place for her is an inpatient medical unit for close cardiac and electrolyte monitoring. And all of this brings us to our final, and you could argue, our most important point. All this clinical knowledge, it's just one part of the equation. It's at its most powerful when it's delivered with genuine compassion. Your ability to build a therapeutic relationship, one that's completely free of judgment, that is one of the most potent interventions you have. So, as you keep going on your journey to becoming a nurse, here's the question I want to leave you with. How are you going to blend this sharp, evidence-based assessment with true, genuine compassion to advocate for your patients and help them heal? Because that combination, that's the true heart of nursing.